Surgery is the definitive treatment for any disease, but it is not without complications. Welcome back to ophthalmology for undergraduates and postgraduate beginners. Today we are going to talk about complications of cataract surgeries. Complications we come across in cataract surgeries can be classified into four types. The first one is anesthesia related complications. In one of my previous videos, I have told everything about anesthesia used in ophthalmology and what are its complications. Kindly refer that video for this anesthesia related complications in cataract surgeries. The next is the intraoperative. While operating, what are the complications that we commonly come across? Early postoperative. After completing the surgery, you can have complications. Early postoperative is up to 4 weeks after doing a cataract surgery. Late postoperative. This is the complication occurs after 4 weeks of cataract surgery. So there is a symptom-free period of 4 weeks. After that, the complications develop. Let us see these things one by one. Under intraoperative complications of cataract surgeries, the most dreaded complications are vitreous prolapse, nucleus or IOL drop, or expulsive hemorrhage. You all know that in cataract surgeries, we open the central portion of the anterior capsule and we remove the cortex and nucleus from the capsular bag and we implant the artificial lens or intraocular lens into this bag. That is what we do. The posterior capsule, which is intact, is only about 4 microns in thickness. It is very thin structure. Within this area, we are doing the cataract extraction and implanting the IOL. Sometimes, because of the degenerative process already that has happened in the posterior capsule, the posterior capsule may give away. It may open, leading to the vitreous getting prolapsed, coming into the anterior chamber, or through the wound it may come out. So this is a vitreous prolapse, the complication we meet in cataract surgeries. If such things happen, we have to do a thorough vitrectomy. We should make sure no prolapsed vitreous is there in the anterior chamber. Then only we have to complete the surgery by placing an IOL which can be attached to the sclera, or you can use a iris claw lens. The next complication is nucleus or IOL drop. This is similar to this problem. The posterior capsule can give away. Before you could remove the nucleus from the capsular bag, the nucleus can fall into the vitreous. This is called as nucleus drop. Sometimes you don't recognize the posterior capsular rupture and you have removed all the nucleus and cortex from the eye. When you place the IOL into the bag, the IOL can slip into the vitreous. That is IOL drop. If such situations occur, we should not proceed further with the surgery. We have to stop the surgery, and such an eye has to be operated by the vitreoretinal surgeon, who should do a thorough vitrectomy and remove this dropped nucleus or IOL. Then they can place a scleral fixated IOL or a iris claw lens. The other dreaded complication during surgery is expulsive hemorrhage. All of you know that when an inflated balloon is pricked with the needle, it will burst. Similar to that, if the eyeball is under high pressure, the intraocular pressure is very high. When you make an incision in such an eyeball where the intraocular pressure is very high, what will happen is the blood vessels inside the eyeball, they can burst, leading to severe hemorrhage, expulsive hemorrhage. They will expel all the contents. You can see here, the blood has come out, the vitreous has come out, the lens is also come out. Everything will come out. All the choroid, iris, ciliary body, sometimes everything may come out and the eyeball can collapse. So that is a very, very dreaded complication for an ophthalmic surgeon. Before doing any surgery, an ophthalmic surgeon should make sure the intraocular pressure is under normal limits. After giving the peribulbar injection as an anesthesia, the eyeball should be massaged very well so that the intraocular pressure is under normal limits. If a surgeon is operating on a glaucomatous eye where the IOP is very high, the IOP should be reduced before surgery by using hyperosmotic agents like oral glycerol or mannitol 20%. That way, we can prevent the complications. With this, I am stopping this video. I will continue in the next video with yearly post-operative complications of cataract surgery.